Hello everyone. So we were discussing about normal labor and its processes, and we have discussed about the stages of labor in the brief in previous video. So today we will be continuing our discussion on the first stage of labor. We will be talking about it in detail. Its definition. We will revise it again. It's what are the events in the first stage of labor. We will talk about clinical course of first stage of labor, and we will be talking finally about the management of the first stage of labor. So, as we have already discussed in the previous video, the first stage of labor starts from onset of the true labor pain and it ends with the full dilatation of the cervix. And it is also known as cervical stage of the labor. And the average duration of first stage is 12 hours according to WHO in primary gravity, and 6 hours in the multiparity women. And according to WHO, it is of 10 hours. So about now we will be talking about events in the first stage of labor. The first stage is chiefly concerned with the preparation of the birth canal so as to facilitate the expulsion of the fetus in the second stage. So the main event that occur in the first stage are one is dilatation and effacement of the cervix, and next is full formation of the lower uterine segment. And we have the first we will discuss about the dilatation of the cervix prior to the onset of labor. In the pre-labor phase, there may be certain amount of dilatation of cervix, especially in the multipara in some primary gravity. But important structural there are various structural changes in the cervix, and that leads to dilatation. Like for example, breakdown of various glycoaminoglycan and other various processes. And these are under the action of hormones like estrogen, progesterone, and relaxin. So the dilatation of cervix is mostly due to the softening of cervix, fibromuscular glandular hypertrophy, increased vascularity, accumulation of fluid in between collagen fiber, breaking down of collagen fibril by enzyme collagenase and elastase, and changes in the various glycosaminoglycans like increase in hyaluronic acid, decrease in dermatan sulfate, and in the matrix of cervix. And these are under action of hormone. And also the in some condition like too much fibrosis, like in the condition like cervicitis, chronic cervicitis, and the prolapse or organic lesion in the cervix, or in the carcinoma, or it result in a deficiency of this factor, and that may result in that can cause the failure of relaxation of failure of dilatation of cervix. So what are the different factors responsible for dilatation of cervix? One is the uterine contraction and retraction due to the uh, due to the contraction of the uterus. There is simultaneous retraction of the cervix, and that causes dilation. Next next factor which might be responsible is fetal axis pressure. That may the fetus in the longitudinal lie and well fitted flexed head on the cervix can cause the dilatation. Stretching that can cause stretching of the lower segment and opening of the cervical canal. And the bag of membrane, the membranes amnion and chorion are loosely attached to decidual lining the uterine cavity except on the internal os. In vortex presentation, the girdle of contact of the head that come the being spherical may well fit with the wall of the lower uterine segment, and thus the amniotic cavity is divided into usual two components, that is forewater and hindwater. So due to the various mechanism like ball valve action and all that thing, and there will be the dilatation of the cervix. As we can see in this figure, due to forewater, we can see the forewater. This is the formation of bag of membrane and forewater. Well fitting of the presenting part be dividing the forewater from the hindwater, and this is forewater, this is hindwater, and the infitting presenting part allows the hindwater to force into the bag of membrane, causing the contraction which may lead to early rupture. And finally, bis arterigo, that means due to the downward thrust of the fetus, it may result in the dilatation and retraction of the cervix. Finally, we have the effacement. There will be effacement of the cervix. Effacement means is the process by which the muscular fiber of the cervix are pulled upward and merges with the fiber of lower uterine segment. So I will repeat again. The muscular fibers of cervix are pulled upward and it merges with the fiber of lower uterine segment. and cervix become thin during the first stages of labor. And in primary gravida, effacement precede the dilatation, whereas in multipara both occur simultaneously, and the expulsion of mucous plugs is caused by effacement. So we can see here in this picture, this is the case in the primary gravida. We can see here the cervix is before the labor. There is progressive taking of the cervix without much dilatation, and here we can see the cervix progressively, the cervix completely taken up, and external loss is still remaining undilated. So there will be effacement, and then only in the latter stage there will be dilatation. Here, but in multipara, the cervix before labor, this is cervix before labor, and this is, you can see also the patella cervix, and we can see the progressive and simultaneously dilatation. There is dilated progressive, simultaneous and progressive dilatation and taking of cervix, and the taking up of cervix and taking up and dilatation of the external loss occur simultaneously. This is the case in primary gravida. Finally, the next third event, that is full formation of lower uterine segment. Before the onset of labor, there is no complete anatomical or functional division of the uterus, and during labor, the demarcation of an active upper segment and the inverse and relatively passive lower segment is more pronounced, and the wall of the upper segment becomes progressively thickened with progressive thinning of lower segment, and this is pronounced in the late first stage, especially after rupture of membrane, and it attains maximum in second stage. And distinct ridge is produced at the junction of these two, called as physiological retraction ring. In this picture, we can see there is anatomical internos, histological internos, and between this is the part between this anatomical and histological internos is known as lower uterine segment. And before, in the early uterus at term, it is there is no functional or anatomical division, but at the early labor, the physiological retraction ring start to form between the main uterus and lower uterine segment, and in the late stage there will be the active segment and passive segment. The active segment contracts, whereas the passive segment is not passive, it does not contract. This lower uterine segment is bounded above by anatomical internals and below by histological internals, as we have said, and it is it corresponds with the isthmus of the non-pregnant uterus. And in labor, it is bounded above by physiological retraction ring and below by the fibromuscular junction of cervix and uterus. Now we will talk about clinical course of first stage of labor. The first symptom to appear is the intermittent painful uterine contraction, and followed by the expulsion of blood-stained mucus, that is also known as soup or vaginum, and only few drops of blood mixed with mucus is expelled, and any excess should be considered as abnormal. And the pain, we have the symptom like pain. The pain is felt more anteriorly with the simultaneously hardening of the uterus. Initially, pain are not strong enough to cause discomfort and come at varying interval of 15 to 30 minutes for the duration of 30 seconds initially, and it doesn't cause any discomfort. But gradually, the interval becomes very shortened with increasing intensity and duration, so that in late first stages, the contraction occurs at the interval of 3 to 5 minute interval, and it lasts for 45 seconds. And the relation of the pain with the uterine contraction has great clinical importance, significance. In normal labor, pain are usually felt shortly after the uterine contraction begin and pass off before complete relaxation. And clinically pain are said to be good if they come at interval of 3 to 5 minutes, and at the height of contraction, the uterine wall cannot be indented by the finger. Nextly, we have the dilatation and effacement of cervix. The progressive anatomical changes in the cervix, such as dilatation and effacement, are recorded following each vaginal examination. Cervical dilatation related the dilatation of cervical os, and effacement is determined by the length of cervical canal in vagina. In primary gravida, the cervix may be completely effaced, feeling like a paper, although not dilated enough to admit a fingertip, and it may be mistaken for one that is fully dilated. While in multipara, the dilatation and taking off occur simultaneously, which are more abrupt following rupture of membrane. Anterior lip of cervix is the last to be effaced, and the first stage is said to be completed only when the cervix is completely retracted over the presenting part during contraction. And the cervical dilation is expressed either in terms of finger 1 to 3 or fully dilated, or better in terms of the centimeters like 10 centimeter when fully dilated, and it is usually measured with finger but recorded in centimeter. One finger and one finger equal to 1.6 centimeter on a. Now talking about partograph, we will make a separate video about partography in detail, but for now what we should know is that the partograph is first of all it was invented by Friedman in 1954. Partograph is a composite graphical record of the cervical dilatation and descent of head against the dilatation and against the duration of labor in hours. It is a composite graphical record of cervical dilatation and descent of head against duration of labor in hours, and it also gives information about fetal and maternal condition, which are all recorded on a single sheet of paper. And cervical dilatation is a sigmoid curve, and the first stage of labor has got two phases, that is latent phase and active phase. The first stage of labor is divided into a relatively flat latent phase and a rapidly progressive active phase. Phase has three compartments and 1 2 3, and the accelerated phase of maximum slope, and deceleration phase. And the presently active phase is defined to start with 5 centimeter or 5 centimeter according to WHO and 6 centimeter according to ACOG. And previously it was the 4 centimeter was taken as criteria, but now according to WHO the active phase is defined to start after 5 centimeter of the dilatation of cervix, and according to ACOG cervical dilatation occurs start after the 6 centimeter of the dilatation of cervix. So latent phase of the labor is defined as the period between the onset of true labor and the point when the cervical dilatation becomes 5 centimeter according to WHO, or it is defined as the period of onset of true labor pain and the point when the cervical dilatation becomes 6 centimeter according to ACOG. WHO says it is 5 centimeter and ACOG says it is 6 centimeter. And in the previously it was taken as 4 centimeter, but it is not regarded now. It is either 5 or 6. So this is latent phase, and the normal duration of latent phase of the labor in the primary gravida is around 20 hours. And in average it is around 8.6. Here we can see 8.6 hour is a normal duration, around 8 points average in the 8.6 in the primary gravida, and 14 hours in the multipara. And the prolonged latent phase does not endanger the mother or fetus, so no intervention is needed. We have the active phase. The active phase has the three components, that is, one is deacceleration phase, the phase of maximum slow deacceleration phase with cervical dilatation of 3 to 4 centimeter, acceleration phase of cervical dilatation 3 to 4 centimeter, the phase of maximum slope of 4 to 9 centimeter of the maximum slope of 4 to 9 centimeter dilatation, phase of maximum slope, and the phase of deacceleration from 9 to 10 centimeter. And the rate of cervical dilatation is less than 0.5 centimeter per hour in a primary, and 0.5 to 1.3 centimeter per hour in multi. Less than 0.5 in primary and more than 0.5 in multi. The rate of descent of the presenting part is less than 1 centimeter per hour in primary and less than 2 centimeter per hour in multi. And it is much slower as compared to the Friedman gap. As we have said, the Friedman gap is older one, and the currently it is regarded that the maximum slope in the cervical dilatation usually start with 6 centimeter, and this graph also shows 4 centimeter, but this is older graph, so it is showing 4 centimeter. But according to the present consortium, on slave labor data, it highlights that maximum slope in the cervical dilatation usually start after with a 6 centimeter. Therefore diagnosis of protracted labor active phase or arrest of labor should not be made before 6 centimeter of dilatation. And In a partograph, the labor process is divided into latent phase that ends with the cervix 5 cm dilated, according to WHO, and the active phase start with the cervical dilatation. The cervical dilatation of 5 cm, and currently the two lines known as fixed 1 cm per hour all out line and corresponding action line has been removed currently, according to WHO, and so there are various new update and controversies regarding this graph. So just for today, this much is, I think this is enough for now. And next clinical course is status membrane. The membrane usually remain intact until the full dilatation of cervix, or sometimes even beyond in the second stage. However, it may rupture at any time after the onset of labor, but before the full dilatation cervix, when it is called early rupture. When the membranes rupture before the onset of labor, it is known as premature rupture. And an intact membrane is best felt with the finger during the uterine contraction, when it becomes tense and bulges out through the cervical opening, and in between contraction the membranes get relaxed and lies in contact with head. And with the rupture of membrane, variable amount of liquor escape out through the vagina, and often there is acceleration of the uterine contraction. In the maternal system, the general condition remain unaffected, although a feeling of transient fatigue may appear following a strong contraction, and pulse rate is increased by 10 to 15 beats per minute during the contraction, and which settles down to its previous rate in between contraction. The systemic blood pressure is raised by about 10 mmHg during contraction, and temperature remains unchanged. And the fetal effect, as long as the membrane are intact, there is hardly any adverse effect on fetus. However, during the contraction, there may be slowing of the fetal heart rate by 10 to 20 beats per minute, which soon returns to its normal rate of about 120 per minute as the intensity of contraction diminishes, provided the fetus is not compromised. Now we will talk about management of the first stage of labor. The principle of management of the first stage of labor are that non-interference with the watchful expectancy, so as to prepare the patient for natural birth, and to monitor carefully the progress of labor, maternal condition, and fetal behavior, so as to detect any intrapartum complication early. The preliminaries are it consists of basic evaluation of the current clinical condition. Inquiry is made about the onset of labor pain, leakage of liquor if there is any, and through general and obstetric examination, including vaginal examination, are to be carried out and recorded, and record of the antenatal visit, investigation report, and the specific treatment if available are to be reviewed. And talking about actual management, the general management like antiseptic dressing should be done, like for example like surgical cleanness, antisepsis, like pubic hair clipping, and all those things we have to do. And next is encouragement, emotional support, reassurance, constant supervision, these are to be done. The position of women is generally women in early labor, normal labor, may not be confined to bed. While in bed, she may take the position most comfortable to her, but she should avoid dorsal supine position to avoid aortocabal compression. And enema is not recommended It neither reduces or shortens the duration labor nor reduces the infection rate. So the maternal rest and ambulance, if the membrane are intact, the patient is allowed to walk about, and this will prevent the vena-cava compression and encourage the descent of head. And ambulation can reduce the duration of labor and need of analgesia and improve the maternal discomfort. In the diet, there is delayed emptying of stomach in the labor, and low pH of gastric content is dangerous if it is aspirated during the general anesthesia, when it is needed unexpectedly. So food is not withheld during the active labor, and fluid in the form of plain water, ice cap, fruit juice may be given in the early labor. And intravenous fluid, the Ringer's lact solution is started where any intervention is anticipated or patient is under regional anesthesia. And the bladder care, patient is encouraged to pass urine by herself, as full bladder often inhibit the uterine contraction and may lead to infection. If the woman cannot go to toilet, she is given bedpan, and all the privacy must be maintained. And if the patient fails to pass urine, especially in the late first stage, the catheterization is to be done with strict aseptic precaution. Next is referral pain, relief of pain. The epidural analgesia is recommended if you want to avoid pain, and the common analgesia is pethidine 550 to 100 milligram or meperidine intramuscularly when pain is well established in the active phase of labor, and if necessary, if it is repeated after 4 hours. And metoclopramide 10 mg IM is commonly given to combat vomiting due to pethidine. And pethidine can cross placenta, and it is a respiratory depressant to the neonate. So this drug should not be given if the delivery is anticipated within 2 hours. Finally, we have to do the assessment of progress of labor and partograph. As a partograph recording should be done, the pulse should be recorded every 30 minutes and the rate is marked in the partograph. And blood pressure is recorded at every 1 hour, marked with systolic and diastolic. Temperature is recorded every 2 hours. The urine output is recorded for volume, protein, acetone. Any drug, oxytocin, when given, is recorded in the partograph. And abdominal palpation should be done, like the uterine contraction as regard the frequency, intensity, and duration are assessed. Uterine contraction and the number of contraction in 10 minutes and duration of each contraction in second are recorded in the partograph. Partograph is started every half an hour as mild in the contraction duration less than 20 seconds, moderate contraction duration between 20 to 60 seconds, and the strong there is contraction is contraction duration is more than 60 seconds. And labor progress, the cervical dilatation, the plot cervical dilatation should be 5 to 10 centimeter. And the pelvic grip, gradual disappearance of the pole of the head, sinciput and occiput, which were felt previously, usually occur in labor. And there is disappearance of pole of the head, which were previously felt, and that disappear. And the abdominal palpation of the descent of the fetal head in terms of fifth felt above the brim is to be used, and the shifting of the maximal intensity of the fetal head be heartbeat downward and medially, that is seen. And to note the fetal well-being, we have to the fetal rate, heart rate along with its rhythm and intensity should be noted every half an hour in the first stage and every 15 minutes in the second stage, or following the rupture of membrane. And so and the observation should be made immediately following the uterine contraction, and the count should be made for 60 seconds. And the following routine clinical observation, ordinary state is quite suitable, and Doppler ultrasonic cardiography duplex, however, is helpful in the cases of obesity and polyhydramnios. And to avoid confusion of maternal and fetal heart rate, a maternal pulse should be counted. Otherwise, maternal tachycardia may be wrongly treated as fetal heart rate, and the normal fetal heart rate ranges from 110 to 160 per minute. Next, we have to do continuous electronic fetal monitoring for high-risk pregnancy, and we have to do vaginal examination for noting the dilatation of cervix in centimeter in relation to hour of the labor is recorded. Position of head and degree of flexion, station of the head, degree of descent, color of liquor, whether it is clear or meconium stained, and if the membranes are ruptured, degree of molding of the head, if the molding occurs first at junction of occipito-parietal lobe and then between parietal lobe. Caput formation progressive increase is more important than is mere present. If there are evidence of fetal distress, then we have to do the intrapartum fetal monitoring, and we have to watch for the maternal condition. Routine checkup include to record 2 hourly pulse, and this is for maternal, okay, and blood pressure, temperature, and observe the tongue periodically for hydration. Note urine output, note acetone, glucose, IV fluid, and drug. And if the evidence of maternal distress are anxious look, dry tongue, rising pulse rate of more than 100, or dehydration, dry tongue, hot dry vagina, acetone smell in breath, and scanty high colored urine with presence of acetone, these are indication for maternal distress. So thank you, and this was about first stage of labor. Now in the next video we will be talking about second stage of labor. Thank you.